All right, so regarding other trends. So the number of uninsured increased dramatically between 2000 and 2009, as we mentioned earlier. Ironically, despite the tax credits under the Affordable Care Act, small businesses insurance coverage also declined. So premium increases between the years 2008 and 2013. 25% were premium increases for single plans, 29% for family plans. Now, the deductible increase between the years of 2008 and 2013, they increased from $735 to $1,135 on an average. Now, for the next slide, we're going to be talking about private health insurance under the Affordable Care Act. So there were numerous employment-based plans that are losing their grandfathered status. So fees imposed on insurers include a flat fee imposed on plans operating outside of ERISA or self-insurance market. Additional fee is imposed on plans sold through the exchanges, and these costs will be passed on in the form of higher premiums. So the compliance requirements for health plans. So we have the coverage of young adults under their parents' plans under the age of 26. Coverage for people with pre-existing medical conditions. Coverage for preventative services without cost sharing. Elimination of yearly or lifetime benefit dollar limits. Caps on annual cost sharing. And targets for medical loss rate ratios. Now, there's also, I'm going to go to the following slide after this, talking about the individual mandate. So when we're talking about the individual mandate, with some exceptions, all legal residents must have a minimum essential coverage or pay a tax penalty. The minimum essential coverage must include essential health benefits in 10 categories. Healthy individuals in particular may choose to pay the penalty instead of buying health insurance. It's completely up to them. Private insurers sell 4 main types of plans through health insurance exchanges. Federal subsidies are available to people with incomes between 100% and 400% of the federal poverty level. Now, before I jump to exemptions from this individual shared responsibility, I do want to briefly cover the topic of employer mandate. It's play or pay. So delayed until January 2015, and that's when it was delayed till. And then after January 2015, it applies to employers with 50 or more full-time equivalent, which is full-time is equivalent to 30 or more hours per week, employees. The employer plans must pass both a minimum value test and affordability test. Penalties apply if an employer's plan fails these 2 tests, or if a full-time worker gets subsidized health insurance through an exchange. All right, so now for the following slide, talking about the exemptions from individual shared responsibility. Having to spend more than 8% of household income on health insurance, they're exempt, as well as religious opposition to insurance and certain other exemptions. So now I'm going to jump to slide number 34 on Medicare, and I will begin speaking about Medicare and the different parts of Medicare. All right, so let me find slide number 34. So Medicare covers the elderly, disabled, on Social Security, and people with end-stage renal disease. People who have paid Medicare taxes and earned 40 credits are entitled. A federal program, it's a federal program, and it's consistent eligibility criteria and benefits across the nation. So I'm going to begin by speaking about Part A, which is the hospital insurance. And it's financed by special payroll taxes collected for Social Security. The Hospital Insurance Trust Fund is financed by a payroll tax of 1.45% from the employee and 1.45% from the employer. All income is taxed. A deductible applies per benefit period. A benefit period is a spell of illness beginning with hospitalization and ending when a beneficiary has not been an inpatient in a hospital or skilled nursing facility for 60 consecutive days. So Part A covers hospital inpatient services, care in a skilled nursing facility, as well as home health visits and hospice care. So the following services are covered. So you have a maximum of 90 days of inpatient hospital care that's allowed per benefit period. Once the 90 days are exhausted, there's a lifetime reserve of 60 hospital inpatient days. There is no limit to the number of benefit periods. Beneficiaries must pay a deductible. The first 60 days are without any co-payments. Okay? So after the first 60 days, co-payments are expected. Now, up to 100 days of care in a Medicare Certified Skilled Nursing Facility, or SNF, are allowed, provided the beneficiary has been hospitalized for at least 3 consecutive days, not including the day of discharge. A co-payment applies after the first 20 days. Okay, and again, that's for having up to 100 days of care in a Medicare Certified Skilled Nursing Facility. Then, regarding home health care, which is covered when a person is homebound and requires intermittent or part-time skilled nursing care or rehabilitation care. No cost sharing applies. For terminally ill patients, so we're talking about hospice care now, Medicare pays for care provided by a Medicare certified hospice. The non-covered services are long-term care, again with the exception of limited skilled nursing facility. Custodial care is not included, and personal convenience. So when we say personal convenience, we're talking about television, telephone, private duty nurses, private rooms when not medically necessary. All right, so now that we've covered Part A, we are going to jump to Part B. Now, Part B is the supplementary medical insurance, or SMI, portion of Medicare. Okay? It's a voluntary program financed partly by general tax revenues and partly by required premium contributions from the enrollees. So as of 2007, premiums are means tested. The main services covered by SMI are outpatient services, such as physician services, hospital outpatient services. So when we're saying hospital outpatient services, we're talking about like outpatient surgery, diagnostic tests, radiology. Also, emergency department visits, outpatient rehabilitation services, renal dialysis, prosthesis, medical equipment and supplies, annual exams, and an array of preventative services. Non-covered services include dental care, hearing aids, and eyeglasses, except for cataract surgery, and services not related to treatment or injury. All right, I know this is a lot of information when we're covering Medicare, so make sure to read this section in your textbook carefully and go through the slides. I tried to break it down so it's self-explanatory. Now, when we talk about Medicare Advantage, it's also known as Part C. It does not add specifically defined new services. It merely provides some additional choices of health plans with the objective of channeling a greater number of beneficiaries into managed care plans. So the Balanced Budget Act, BBA, of 1997 authorized the Medicare Choice Program, which took effect in 1998. So the Medicare Plus Choice was renamed Medicare Advantage through the passage of the MMA in 2008. So beneficiaries can either choose to enroll in a managed care plan, or they can remain in the original Medicare fee-for-service program. Medicare Advantage plans, they may offer additional benefits that are not offered by the original Medicare plan. They also may have lower out-of-pocket costs. Now, in the next section, we are going to cover the topic of Part C, or Medicare Advantage, under the Affordable Care Act. All right, so with the Affordable Care Act, the aim is to reduce payment to Medicare Advantage plans by 8% in 2014. The goal is to achieve some level of parity between the expenditures for Part C compared to expenditures in the original Medicare program. The government has contended that the Medicare Advantage, or MA, plans have been overpaid. Now, the next slide covers the topic of Medicare Part D. So this is also voluntary. It was created under the MMA in 2003, and it was implemented in 2006. So the focus here is prescription drug coverage. Premium costs are shared between the government and the beneficiary. Enrollees can choose between a standalone prescription drug plan for those that are not enrolled in Part C, or Part C, in which all services are delivered through managed care. Cost sharing goes through 4 stages: deductible, basic levels of care, a coverage gap, and a catastrophic coverage. All right, so let me jump to the next slide. All right, so we touched on the 2 types of private plans in the Part D. And next is a video on Medicare and Medicare Advantage. There are actually 2 different videos. I'm going to show you here the overview of Medicare, and then I will continue the presentation. So this is a short video on Medicare, just to kind of go over what we've covered, and then I will be jumping into the topic of Medicaid.
Okay, so you're trying to understand Medicare, and it can be really confusing. Like, when do you have to start thinking about all this stuff? Well, if you're coming up on the magic 6-5, it's time. Or if you're like a lot of us and retiring later, you're ready as soon as you don't have employer health insurance anymore. Maybe you'll already have a Medicare plan, but you're thinking about switching it up a little bit. No matter what's going on, you need to know some basics. So let's get started. Medicare has 4 parts: A, B, C, and yep, you guessed it, D. Plus there's this 5th thing called supplemental. We'll get back to that. So what do the letters really mean? Well, Part A is for when you go to the hospital. Dr. Becker. And you get it just by signing up for Medicare. We have a whole nother video that explains signing up. For most, you get Part A automatically, and it costs you zero, nothing. Parts B, C, and D, on the other hand, are optional. If you want them, you buy them. Part B is for when you go to the doctor. Stuff like routine physicals, blood pressure checks, tests, things like that. Part C, well, let's say you want to add eye care or dental coverage or something else. That's where Part C comes in. It's also called Medicare Advantage, and it's pretty cool. Part C combines A and B along with some of the other stuff you want. Then there's Part D. Part D is prescription drug coverage. Now, you can buy it on its own, or you can get it with Part C and wrap the whole thing up in one neat little package. You can also buy a supplemental policy if you want, They're called that because they cover some of the costs not included in A or B. Well, there you go. Those are the basics.
All right, so now I'm going to go through Medicaid, and then I wanted to show you a video on it, and we'll see where we go from there. So now, regarding Medicaid, I wanted to touch on the old options before the implementation of the Affordable Care Act, and then we could talk about how Medicaid coverage is under the Affordable Care Act. So, old Medicaid option, we're looking at states that determine eligibility based on income and assets. Three main categories of people are automatically eligible. You have families with children receiving support under the Temporary Assistance for Needy Families program, people receiving supplemental security income, and children and pregnant women whose family income is at or below 133% of the federal poverty level. You also have dual eligible beneficiaries. So what this is, it's when a person qualifies for both Medicare and Medicaid. Under the Affordable Care Act, Medicaid will become the new vehicle for health care services for this population group. Both income and asset tests will be applied. Now, Medicaid under Medicare. All right, I'm going to jump to slide number 44. Now, Medicaid is found in all U.S. states, District of Columbia, and U.S. territories. Eligibility criteria, covered service, and payments to providers vary from state to state. So let's look at Medicaid under the Affordable Care Act. So coverage for legal residents under the age of 65 with income up to 138% of the federal poverty level. There is coverage for them. States can no longer use the assets test. Federal matching at 100% for newly eligible individuals for 3 years, from 2014 to 2016, with a gradual reduction each year to 90% in 2020. Beneficiaries who already are in the Medicaid program, coverage for preventative services is at the discretion of the state. So states have the option to establish health homes, not to be confused with home health care. Health homes are different, for Medicaid beneficiaries who have chronic conditions, including serious and persistent mental health conditions. Now, you need to keep in mind that the Supreme Court's decision leaves the program in an uncertain situation, right? Because many people as states have a choice to either comply with or not comply with the requirements of the Affordable Care Act. States that refuse to comply will carry out the traditional program. So when I spoke about the old Medicaid option, that was designed for the most financially needy. Income and asset requirements will have to be met by a means test. Those are for the states that do not participate in the Medicaid expansion plan. All right, these topics I have already went over. Old Medicaid option we've already covered. So now I'm going to jump to the Medicaid, understanding Medicaid coverage video. All right, so here's the video on Medicaid coverage.
Medicaid is a U.S. healthcare program that finances the care of low-income and certain high-risk populations, including low-income children and families, people with developmental or physical disabilities, low-income nursing home residents, and others. Unlike Medicare, which is a federally funded and administered health insurance program available to everyone over 65, regardless of income, Medicaid is a need-based program funded jointly by the federal and state governments and administered at the state level. In 2009, Medicaid financed the care for nearly 20% of all Americans, making it the largest source of medical coverage for the country's low-income population. In the coming years, under the Patient Protection and Affordable Care Act, Medicaid will expand to cover a much larger proportion of the population in certain states. And yet, despite the growing importance of Medicaid, most Americans do not understand how it is funded. Medicaid begins with a mix of federal and state funding. The federal government makes annual Medicaid payments to states based on their federal medical assistance percentages, or FMAPs. Each state's FMAP, which is determined by a formula that looks at state per capita income relative to the U.S. average, is set somewhere between 50 and 83%. This means the federal government pays between 50 and 83 cents of every Medicaid dollar, leaving the state to pay the difference. While the proportion of federal and state dollars is set each year, the total amount is unlimited unless the state and federal government have agreed to special financing terms under a waiver of the Medicaid rules. These funds can be further supplemented through a number of different federal grants. A state may use alternative sources of income, such as tobacco or provider taxes, to fund its Medicaid program. This accumulated pool of healthcare money helps to fund the populations in a given state. If people have other sources of healthcare funding, such as Medicare or employer-sponsored insurance, those parties may have to provide funding before Medicaid, since Medicaid is a payer of last resort. While the federal government has mandated legal minimums for Medicaid, including minimum access to care, eligibility requirements, and medical service requirements, there remains great flexibility from one state to another in how programs are administered. One of the ways states utilize this flexibility is through waivers, which allow for expanded services and enrollment, and in some cases allow innovative solutions. Each state establishes the reimbursement rate that will be paid to hospitals, physicians, pharmacies, and other healthcare providers. Medicaid reimbursement rates are typically lower than those paid by Medicare and commercial health insurance carriers. While most Medicaid payments are made to providers based on the services performed, other financing components sometimes complicate the picture. These may include special payments to providers that provide care to a high number of low-income populations, rebates paid from the pharmaceutical